Welcome back to the Popped Podcast, where we uncover real, raw, and rarely discussed truths about pregnancy, birth, postpartum, and beyond. I'm your host, Dr. Emily Mary, prenatal and postpartum chiropractor, birth doula, and founder of Move Moms at Move Chiropractic Boulder. Today, we're diving deeper into labor inductions, but this time we're going to look at the science behind and through all of these labor induction types, what the cascades can be, what they can not be, and what these different changes in the body can mean for your labor and birth experience. Hopefully this episode is super beneficial for the moms who need to know the information, who like to know the science behind what is going on physiologically, biologically, all the different chemistry that starts to change in the body when these induction measures take place inside of us through our labor experience. Let's get into it. I'm super excited. You'll find that this episode has some repetitive pieces from other episodes that we've talked about in the past, whether it's waters breaking or baby's role in labor or positioning of baby. There's lots of different things that coincide with each other that affect or are affected by these different labor induction types. So going off of our natural labor cascade, not because that's everybody's dream labor and birth experience, but because that is typically what we're working off of, or what our hospital workers, our birth teams at hospitals or even birth centers or even home births are working off of to find this natural experience pattern or rhythm through your labor and birth experience. So I wanted to start with the natural cycles of labor so that we can start to see where these induction pieces can fit into this natural cycle. This section more is trying to show you what inductions are trying to replicate or what they're trying to start. So labor does not begin from one signal. It begins with multiple systems aligning in one specific time in your pregnancy. The body prepares for labor long before contractions ever start. The major systems involved are going to be maternal hormonal signaling, cervical tissue remodeling, uterine receptor sensitivity, nervous system regulation, and fetal signaling via lung maturation. All of these systems aligning at once is what really allows a mom's body to go into that natural cascade of labor and birth. So I want to dive into that fetal surfactant protein A, or that cascade of events that I've talked about in previous episodes. I think specifically the waters breaking episode. But with surfactant protein A, it does start the cascade of most natural labor cycles. We don't always understand what that is. I say it all the time in the office, so I think a lot of our Move moms understand what I'm saying. We're waiting for the baby's lungs to be ready to send out that surfactant protein A. I've said it before in other episodes, so go listen if you need to get a little reminder. I think it's in the water breaking episode. As babies' lungs mature late in pregnancy, they start to produce this protein called surfactant protein A. These proteins don't just stay in the lungs. They actually go out into the amniotic fluid. They start circulating in mom's belly, and from there they start to interact with maternal tissues and her immune pathways. This signaling starts to help increase the prostaglandin production and release of prostaglandins. It activates the inflammatory pathways involved in cervical ripening, and then it also starts to communicate fetal readiness for birth to the mom's body. Hey, we've got surfactant protein A circulating in the amniotic fluid. Now's the time that we can start doing those cervical ripening measures within the body. We can start relaxing pelvic hip muscles and external hip rotators and softening all the tissues to allow for those contractions to actually have tissue to use to contract. This is one of the clearest examples that labor isn't something that's done to the baby, but labor is something that is initiated with baby. And all that to say, maternal preparation still matters. There's still a lot happening on the maternal side, not just baby saying, okay, mom, come on, I'm ready for birth. Yes, that is part of it, but again, this is a done together process, not done by one or the other. So the maternal preparation that still matters, that's happening in mom's body, is rising estrogen that increases uterine excitability. We have oxytocin receptors multiplying in the uterus. We have prostaglandins softening and thinning the cervix. We have cervical changes that happen before active labor. So that's collagen loosening, that's just tissue loosening in your body. Water content increases, and then tissue becomes more elastic. And we've talked about this before. We've got baby's mechanical role. So engagement into the pelvis increases cervical pressure. That cervical pressure sends off lots of signals up through the nervous system, through hormones, through lots of different tissues in the mom's body to let the body know, hey, we're ready for the next stage or the next phase of labor. There's lots and lots of little stages and phases for every single mom, and they're all different. We look at main basic stages like early labor, or active labor or postpartum. We look at these big stages, but all these tiny stages in active labor, in early labor, these all matter too. And baby's going to create pressure multiple times through all of these different stages in different ways, in different positions, in different amounts to allow mom's body to work with baby to guide baby out. The pressure enhances prostaglandin release. We know that prostaglandin release allows the cervix to ripen, soften, expand more and more and more. The position of baby, depending on how they're engaging in the pelvis, starts to influence how efficiently the cervix can receive signal. Again, why it's so important to make sure that we have got positioning down prior to going into labor and birth. And that's not to say it's the easiest thing in the world to have position down or have your position locked and loaded. It's something you have to work on and work on and work on all the way through your pregnancy, all the way to the end. At no point do we really just take a break and hope the baby stays in the same position. Ideally, this allows these small stages of labor to be experienced in the body more clearly and not so confusing. Not stalling labor, but just elongating labor. If baby's in funky positions, or if your body's in funky positions and not allowing baby to utilize all the different positioning that they need in order to come out, go back and watch baby's active role in labor. They need space and they need movement so that they can work their way down into the pelvis and through the pelvis. So position influences a lot, not just baby, but it influences you and you influence you and baby's position. So keep moving, keep making sure that we always are looking at position. Double extra PSS note on that is, or PPS, whatever the extra note is that you add at the end of a letter, is to have a doula in the room to help with this positioning, to allow baby to utilize all the different positions that can come through during labor so that they can engage and work their way through and out of the pelvis. The nervous system overlay that happens in natural labor. Labor requires a balance between activation, work, and safety, which is progress. So stress hormones can actually stop the release of oxytocin and stop oxytocin signaling from the body up to the brain and vice versa. And then calm and perceived safety within the environment will help that hormonal flow for the nervous system signaling. Spontaneous labor is a conversation between baby, hormones, tissues, mom, the nervous system, and it's not always a single switch, but a lot of times it's patients allowing each of these systems to really start to line up. Sometimes we don't always give enough time for the systems to line up, or there's fear or worry baked into the initial experience of going into labor, or even prior to going into labor, that doesn't allow for some of these systems to start aligning. And that's where we start to see some of these induction measures come in and take over some of these steps. Sometimes it just allows us to get back onto that road of a natural rhythm. Sometimes these induction measures take over what our body was trying to do or where it got stalled, and then needs a cascade of more help to get through to the end of labor and birth. So I want to move into what the science, the cervical ripening agents, what prostaglandins are actually doing. So we talked about cervical ripening last time. That's going to be your cytotec or cervidil. And again, I want to be super clear going into this section. Cervical ripening does not mean you are starting labor. Cervical ripening is truly the pre-labor cursor. The precursor to labor. I really meant to say it that way, but anyways. The cervical ripening agents are designed to act on the cervix, not on the uterus. The uterus is going to be what's contracting to push baby out. Our cervix is really just the portal of exit for baby to come out. So that portal of exit, that portal has to be prepped just as much as any other tissue to push baby out. That tissue that's pushing baby out can be as strong as humanly possible, or even more than humanly possible. But if that portal of exit isn't prepped or ready, there isn't going to be space for baby to come out, or baby's going to push through and mom is going to experience severe tearing. So we're trying to avoid that, right? The cervix is mostly connective tissue. It's rich in collagen. What does oxytocin work most on? Collagen. We want to make sure that this collagen is getting the most signaling from our nervous system. Our nervous system only works in movement and in proper positions. It doesn't not work in specific positions, but in specific positions, let's say you're curled up in a tiny ball, sometimes those positions send different signals to the brain that are not going to be conducive for your body, the same as being in a big, open, deep squat for labor and birth. Obviously, you wouldn't be in a curled up ball for labor and birth, but just trying to pull that imagery into your head that different positions in the body send different signals to your brain. Depending on the positioning of your body, we're going to allow that oxytocin to more clearly get down to that collagen tissue in the cervix. Before labor, the collagen must loosen, reorganize, and hold more water. There's going to be lots of water, hydration needed in those tissues for that elasticity, for that stretch, all the way through all the different stretches, movements, positions baby's going to use while engaging into and through that cervix tissue. Prostaglandins are the primary mediators of this change. We talked about prostaglandins a lot. We can see prostaglandins a lot when we talk about membrane sweeps, so you'll hear me talk a lot about those in a little bit. But prostaglandins are a huge messenger. It's I like to think of prostaglandins kind of like the owls in Harry Potter. They're bringing super, super important messages to the wizards so that the wizards can do their whatever magic. So these owls or these prostaglandins, once they get released, once they get a signal or enough signal to release and then go do their job, which is to tell the message to the next activator of the body, hey, we need to start activating the inflammatory processes. We need to start activating this tissue change. We need to start activating this protein change, this hormonal change. So prostaglandins do a lot, but in order for them to do their job, they need to be released somehow. In order for them to be released, we're either going to have that surfactant protein A come and signal to them, hey, it's time to be released and go on and do your job, or we have the membrane sweep. Either way, prostaglandins usually somehow are coming out and starting a lot of the cervical ripening process. Without them, it'd be really difficult for your cervix to be soft enough for baby to come through. This process is sometimes called cervical remodeling, as you heard me call it earlier. In spontaneous labor, this happens gradually over days or even weeks leading up to the labor process, or leading up to early and active labor. Why does ripening happen before contractions? Why would this be a labor induction method if you haven't even started contractions? Well, like we said, we need cervical ripening before contractions have started. Why is that? A firm, closed cervix resists dilation. So if you have a closed, firm cervix, it's not going to want to stretch open and dilate. Strong contractions against an unripe cervix are often way more painful, and they're often not very effective for cervical change or for baby's position change. Ripening prepares the tissue so that contractions can actually do something. I've talked a lot about this in terms of prepping the pelvis muscle-wise for labor and birth. If you have tight muscles, the definition of a muscle is to support. It has the ability to contract or lengthen at any given time, and lengthen meaning stretch. So a muscle, if it's just normal, it's bouncy. It can either contract and become tight, or it can stretch. But if a muscle's stuck in contraction, it contract more, and usually it can't stretch. It's already doing a function. It's contracting. It's already tight. Different because it's tissue that's not muscles, or it's not muscular tissue, but it's still connective tissue. When a cervix is tight, it's really hard for it to just open up. There has to be some other effect, massive effect of change on the tissue itself before it has the ability to stretch and open. So if we have a tight cervix, we cannot stretch it. It's not going to stretch open and then allow for motion for baby to come through. If the cervix is prepped, it has been, again, because it's not muscular tissue, it's going to have completely different ways of being contracted or stretched because it's not a muscle. So ripening is actually going to allow us to put the tissue of the cervix in that state where it has the ability to lengthen, has the ability to contract. It's not just stuck in that tight position. When we have that looseness in the cervix, we actually have the ability, when the contractions come through, to create tightness, to create stretch, to create openness, whatever it is. So with stretch, with ripening in those tissues, they actually have the malleability to do what they're supposed to do, which is move, help, stretch, and get baby through the birth canal. Just because cervical ripening is supposed to happen prior to contractions doesn't mean that it's always going to. So sometimes when we use ripening agents or cervical ripening induction measures, sometimes they start to create contractions anyways. So why does this happen? Prostaglandins don't just affect the cervix. They also increase uterine sensitivity to oxytocin, and they lower the threshold for contractions. So naturally, your body is going to have an easier pathway to starting contractions when we start with cervical ripening induction measures, typically in a hospital. I'm going to keep saying in a hospital because typically the birth centers here in Colorado do not do any form of induction. So again, when I'm saying in the hospital, it's just because here in Colorado, you're usually experiencing the induction measures in a hospital setting. This is why some people experience, when they're using cervical ripening agents as their induction measure, this is why some people experience cramping, early contractions, or quote unquote, because we've already talked about this before, the false start that doesn't turn into active labor. Remember, there's no such thing as a false start. If you're not watching this episode, I just use my little air quotes. There's no such thing as a false start. This is just your body prepping and practicing for labor. However, you might experience more practice for labor, or what feels like more practice for labor, if your body experiences or goes through a cervical ripening agent like Cytotec or Cervidil at the hospital. Sometimes you'll experience some of what you might have been experienced the prior weeks before or days before at home with some random contractions at home without it actually cascading into active labor. And the important distinction for our cervical ripeners is that cervical change does not equal a coordinated labor. You can be softer and not be contracting. You can be contracting without effective dilation. Ripening is just preparation. It is not typically propulsion into labor and birth, except for some people. I'm almost done with this section, but I do have to do a little tangent on Cytotec. Cytotec is known with different doses. I actually don't know if I put this in the episode last week, so sorry if this is repetitive, but Cytotec is known for multiple doses or having too much of a dose in one body. There's something called a cytobomb, and the cytobomb allows your body to, or takes your body typically from 0, 1, 2 centimeters dilation to 9 or 10 centimeters of dilation quickly. It can happen in 10 to 40, 50 minutes. It can happen really, really quickly, and then baby can be coming out extremely quickly. Cytobombs typically lead to pretty intense complications, either with mom or baby or both. So this is something that I think is really, really important to stay wary of, especially if you are deciding to start with a cervical ripener. Again, like I said, I don't want to say there's nothing wrong with cervical ripeners, because obviously cytobombs, that's something wrong with cervical ripeners. But if this is an induction measure that you want to take, this is the way that you want to go, definitely be wary of that dosage, and maybe ask your providers about it when you're starting Cytotec. What is the dosage? Are we sure that this dosage is going to be appropriate for me? And then when they're administering the dosage, you can confirm that the dosage is the proper amount, or you can try to confirm that the dosage is the proper amount that you've already discussed prior, so that you are have more of a chance of not experiencing that cytobomb. So in natural labor, prostaglandin exposure is gradual and regulated typically. Some people it happens a little quicker than others, but most of the time it's very gradual and regulated within the body. with medications, that process is much more concentrated, it's a lot faster, and it's less responsive to feedback loops that the body would typically start to create over that gradual and regulated time in a natural labor. That doesn't mean that cervical ripeners are wrong. It doesn't mean you're wrong if you decide to start your labor with an induction through cervical ripening tools. It just means that your body is being asked to adapt quickly, and so you need to be prepared for that. Sometimes that adaptation brings on the intensity of labor and birth a lot quicker than some other people experience with a natural labor. Not to say that I don't have my natural labor mamas who have quick, fast, intense labor and birth. So, anyways, sometimes that intensity can be the cascade into more medications, more pain relief, and that's where some people see, okay, if you start with an induction measure, it's always going to cascade into all of the medications that are needed or quote unquote needed, end up needed for a medicated labor and birth. That's not always the case. Like I said last week, I have many moms who started with Cytotec or Cervidil, and that's all they needed in order to get into labor, and they did not utilize any pain medication after the Cytotec or Cervidil was administered. So just know that sometimes when a body has to adapt this quickly to massive changes, the intensity of the experience can go up, and sometimes that intensity can be correlated or translated into pain in some bodies, and that's where we start to see the additional medications or pain relief added into the birth plan just based on the intensity or the quickness of labor starting. So something to think about. Like I was saying, cervical ripening agents are asking the cervix to behave like it's been preparing for weeks in a much shorter window of time. So if the chemical signals don't initiate enough change, the next step is often mechanical, using pressure to create the same message. So watching the episode back last week, anytime I edit these episodes, sometimes I'm like, dang it, I forgot to say XYZ. And so I try to pick it up in the next episode, and I rarely do, but because I happen to be talking about inductions 2 weeks in a row, this week I can pick it up a little bit. Why was I saying that mechanical cervical inductions are my preference over hormonal or Cytotec Cervidil type inductions? Typically, I have already been prepping most of my moms at my office, my doula clients, with cervical ripening tools. They have been working on cervical ripening since typically week 32, 33, 34. So we've been working on cervical ripening, and that's why when we come to induction measures, if necessary, that's why I'm typically starting with mechanical measures, because in our perspective, we've already prepped the cervix. Not every mom, but a good portion of my moms will ask for a cervical check, and they do have a good amount of cervical change. That's why a lot of my moms who do need or want to start with an induction start with a mechanical induction over hormonal induction, just because their cervix is ready to start the mechanical. And with the mechanical, I like it because we haven't already shifted any hormones or proteins or anything else. We're simply shifting the mechanics of the body, which then can initiate a signaling of other signals, of other hormones, of other natural signaling that might have been shifted or changed. Like I just said, some of the feedback loops get changed when you do cervical ripening agents. When you do mechanical cervical dilation, sometimes those feedback loops are opened up and more clearly expressed because we're actively changing the feedback loop, that we're mechanically changing one of the processes that is going to allow space for baby to come out. I know that was not super clear, that last part, but all of that to say, mechanical cervical dilation is just going to allow the body to feel the change before it just sees the change. It's a difference of, if you have a headache, think about being 10 years old and having a headache, and you might have your mom or your dad saying, okay, you can take Advil, we could put a cold pack on your head. And you might do both. You might take the Advil, and are you feeling anything yet? Are you feeling anything yet? Are you feeling anything yet? Like, you don't know if you're feeling anything for however long. But in that space, that time for that Advil to take effect or start working in your body, you might put a cold pack on your head or a wet washcloth. And that physical change, that physical feeling, that outward, like tactile touch, the physical change that you can feel on your body or in your body often allows for the expression of anything else to start. So sometimes you could put a wet washcloth on your head and actually start to feel better a lot quicker than the Advil working. Even though the Advil might start working, it's just inside. So it's making changes that you don't always get to see or feel so clearly as an outward, external, physical change, if that makes sense. So let's dive into these mechanical cervical dilations. Mechanical dilation works through pressure, not hormones. The common examples that we see are the Foley balloon or the Cook catheter. Both of these devices sit just beyond the cervical opening and they apply a steady pressure and stretch. The cervix is highly responsive to mechanical stress. So stretch will trigger local biomechanical receptors, including prostaglandin release, inflammatory signaling, which is normal, not pathological. We actually want the inflammatory signaling during labor and birth. But this is similar to how the cervix responds to baby's head descending and pressure during spontaneous labor. That's why we like the mechanical pressure. We want baby's head descending. We want that pressure. We want the body to think that baby's head is descending so that it can start encouraging baby to descend by ripening the cervix, by opening the tissues, by creating space for baby to descend, by sending those signals up to the brain. Hey, there's pressure on the cervix. Then the brain can start sending out the natural pain relieving chemicals, the relaxant to allow the hips to open up more, to allow all these different processes to start take place that we need for labor to continue to progress and then eventually into birth. So even though I feel like I've explained it multiple times, what is mechanical dilation actually doing? It physically stretches the cervical tissue. It encourages thinning or effacement. We've talked about effacement versus dilation. Effacement is the thinning of the tissue, the softness, the stretchiness of the cervical tissue. Mechanical dilation also signals the cervix to begin opening, and it promotes local softening without systemic hormone exposure, which is pretty cool. A lot of times when I talk about like Advil, ibuprofen, when we take these random drugs, any drugs most of the time, when they come into our body, they're affecting your whole body most of the time. Not always, but a lot of medications affect your whole body, not the one specific thing that you're trying to affect. Let's move on. What does mechanical dilation not do? It does not directly stimulate uterine contractions, but because of the physical change, can sometimes signal to the body to start them. It does not activate oxytocin release from the brain. However, with change, can start to encourage contractions to start, which can in turn start to encourage that natural oxytocin release. And it does not ensure labor will follow, but that's just the name of the game with induction measures, with medication, with pain relieving chemicals. We don't always know what's going to work until we try it. And not that we always need to try everything to know if it's going to work, but thought I might as well say it. So why is this method often used early over other methods? It separates cervical readiness from uterine activity. So it's more useful when the cervix is firm or closed and contractions are not yet appropriate. This allows the body to progress in stages rather than all at once. Again, ideally, we have cervical ripening happening before contractions, so this is not specifically to start contractions. We're still trying to ripen the cervix. We're still trying to ready the cervix. But like I said, if you are one of my move mamas, we've probably been trying to ripen the cervix for quite some time, but a ripe cervix doesn't always mean a dilated cervix. So sometimes you can have that effacement without any dilation, and these mechanical measures would really allow for a soft or ripened cervix with a mechanical induction to have that mechanical shift or change pretty effectively in the body. And just like everything, responses to this type of induction measure are going to vary across the board. Some bodies respond really quickly to stretch. Others dilate with contractions starting. Others require additional signaling to get things going. This variability reflects tissue responsiveness, nervous system state, and baby's position and engagement. Mechanical dilation uses pressure to ask the cervix to open, without asking the uterus to start working. This is just one of those trying to align the body in all of those different states, all of those different systems, so that the body can really find its natural labor rhythm cycle. This doesn't always allow that for everybody, but this is where we can get a good start in making sure that that cycle is ready to go. Because I talked a lot about this last week, there's not a huge change in the science with membrane sweep, so I'm going to go through this portion just a little bit quicker. Also, we've talked about this a lot in that Waters Breaking episode. I'm pretty sure it's that episode when we talk about membrane sweeps and how they can initiate some stuff, or baby's role of labor. So I'm not super sure, but either way, I've talked about this before, so sorry if this is, again, super repetitive. I'm probably being repetitive saying this is being repetitive, but let's keep going. A membrane sweep separates the amniotic membranes from the lower uterine segment near the cervix. Separation is not random, it targets local prostaglandin release. The goal is not force, but localized signaling. Again, prostaglandins, once they're released from the cervix, they go on and do a cascade of other signaling to allow the body to start this labor process, eventually leading into contraction. What a sweep is actually doing, mechanical separation stimulates the release of prostaglandins. So like I just said, it's doing exactly what the body naturally is supposed to be doing over weeks, days, very gradually and regulated by the body. But sometimes we do it with one mechanical use of our bodies. Prostaglandins, they promote cervical softening, they increase uterine sensitivity to oxytocin. The effect is local, not systemic. So a membrane sweep often is not the trigger for labor to just start. Like I said last week though, for some women it can be. Some women, it can be the one thing you need for labor to start. The sweeps depend heavily on timing. Sweeps are most effective when the cervix is ready and somewhat soft or open. Baby is already a little bit engaged to some degree, and hormonal readiness is already present. If the cascade hasn't begun, the signal has nowhere to land. So if we do a membrane sweep, but nothing else is ready, usually nothing happens within the body. That's why sometimes I'll have patients come in and they've been like, I had a membrane sweep last week and then I had another one this week, and they keep having these membrane sweeps but nothing is happening in their body. It's because some part of that system is not already aligned. So when they have the membrane sweep, any prostaglandins that are being released, they have nowhere to land their signaling to start the rest of that cascade of labor and birth experiences in the body, which is also why responses vary so much. The variation of responses to a membrane sweep reflect physiological readiness, not failure. So keep that in mind. Some people will experience cramping, contractions, and labor within 24 to 48 hours. Others experience no contractions and no cervical change whatsoever. So this one is not one of those, they always work for everybody. This is for sure going to start contractions. This is going to for sure get you to 4 centimeters dilated. This one is kind of a shot in the dark, and if your body's ready, your body's ready. If your body's not, it's not. Why membrane sweeps are often called natural and why that tends to be misleading. I wanted to talk about that because I talked about it last week a little bit, but I didn't feel like I really hit home why they are actually not as natural as we all tend to think that they are. I think we think they're natural because you don't have to be hooked up. This is something you can get done at a birth center. This is technically something you could try to do yourself at home. I do not recommend it whatsoever at all. But this is not technically natural because your body could be doing this process on its own without any physical mechanical touch. But sweeps do not introduce medications, but they are still an intervention. They artificially create a signal to the body that would normally generate on its own. So again, information is always great to have. If you are somebody that does not want to have any form of intervention, add membrane sweeps to your list because membrane sweeps are a form of intervention. The important distinction I want to make with our membrane sweeps is that a sweep supports an already primed system. They do not override the need for cervical readiness, hormonal alignment, and nervous system safety. All of those things have to be present in the body in order for this to land at all. There's no chance that a membrane sweep is going to override your cervical readiness. That is going to override any hormonal alignment. That is going to override your nervous system safety. If some of those things are not in check, it's not going to happen. Our artificial rupture of membranes, so this is breaking your waters, usually with the hook. We've talked about this all the way back in our waters breaking episode. I know for sure it was in that one. This does not tend to come up as a typical intervention thought or topic, but it is common. It is an option, and it is an intervention method. It is an induction method. So I wanted to talk about it a little bit more scientifically this week. Artificial rupture of membranes, AROM. I'm probably just going to call it AROM for the rest of this section. It does not create hormones. It does not ripen the cervix. It changes the physical environment of labor. Like we've talked about, the amniotic sac actually cushions the baby during contractions. It creates this really safe environment for a baby. It helps distribute pressure evenly around their body. It allows baby to rotate and descend gradually, and it acts as a buffer between the uterine force and fetal tolerance. But when the amniotic sac has broken and waters have started to be released, amniotic fluid volume starts to decrease depending on, remember, forewaters or hindwaters releasing. Sometimes we have multiple waters releasing throughout labor, and that's okay. That's babies just shifting their position. Baby's head applies direct pressure to the cervix. Cervical change or cervical stretch increases, and this can intensify contractions. It can increase dilation. It can increase dilation efficiency if labor is already underway. Why does AROM assume readiness? We can only assume readiness with AROM because this intervention really only works best when the cervix is already favorable, contractions are present and or intermittent. They can be far spaced in between. They can be not super intense. Baby is well positioned. If the uterus isn't already coordinating contractions, labor may stall, and additional stimulation is often needed when waters are broken and the uterus isn't ready. The clock factor. Once membranes are ruptured, the infection risk becomes part of the conversation. So, like we've talked about many times, as soon as your water breaks, with any sort of supervision at all, typically there is a timer. There's a clock put on it. We are now looking at risk of infection for both mom and baby. So it's really important that when waters are broken, if AROM is used, it's at a time where we are confident that mom is going to be able to progress through labor into birth in a reasonable amount of time. This is not a physiological requirement. It's clinical reality and typically safety for mom and her health. It often increases the intensity of labor quickly. It often increases the sensations, the timing, the adaptability to labor and birth it turn up tenfold really quick. So a lot of times, from what I've seen from my moms that have used AROM in the middle of labor, a lot of these moms were already 6 or 7 centimeters dilated, where we were seeing labor start to stall, where contractions were getting longer and longer in between. Mom she was able to talk through contractions, whatever it was. Then we had AROM, and she's asking for an epidural. She's asking for a TENS unit. She's asking for anything that can give her any sort of pain relief because it's so intense, it's so painful. And then baby comes because she was already actually really close to the end. We just needed some pressure from baby to come down and open it up. So a reframe for breaking waters. Breaking the water does not start labor often. It removes a buffer and increases pressure, and that pressure can either enhance a labor that's already ready. It can also expose a system that isn't. Be really thoughtful when we're breaking waters if it's really necessary, if labor is actually stalled, or if we're being impatient, or what is happening. What's happening where we're not progressing in the time that we would like to. And Pitocin, we've talked about Pitocin so many times, contracting the uterus without the brain. Pitocin is our synthetic oxytocin. Its primary role is to stimulate uterine muscle contraction. Unlike natural oxytocin, Pitocin does not originate in the brain, it does not cross the blood-brain barrier, and it does not participate in neurohormonal feedback loops. So, synthetic, it's fake. It's just not true what your body truly wants to experience during labor and birth. And so often we find this really asynclitic, I meant to say arrhythmical. We find this really arrhythmical cycle if you want to call it a cycle, it's this arrhythmical experience for most moms on Pitocin. How natural oxytocin typically works in the body is it's released and it pulses from the hypothalamus and your posterior pituitary. The pulsatile release allows for contractions, rest, and regulation. The feedback loops respond to pain, sensitivity, touch, and the emotional state. Oxytocin works alongside endorphins, which is our pain modulation, and then our catecholamines, which is timing and intensity. Your body is literally designed to help you with labor and birth. It has natural chemicals already baked into your system to help get through the intensity of labor and birth. This is not to say that it's easy to do without medication. I realize that. I'm just telling you, how cool is it that your body has very, very specific mechanisms to help with the very, very specific mechanisms that come with pregnancy, labor, and birth. To have endorphins that modulate your pain and that catecholamines that help you stay in a rhythm and a timing to help the contractions, help baby get down and out. How flippin' cool is that? I think it's one of the coolest parts of labor and birth. Yet it's one of the parts that I often see not get to be expressed when I'm in a hospital setting, because a lot of times Pitocin is introduced. Not always, but a lot of times. So how does Pitocin work differently than what I just went through with oxytocin? It's delivered intravenously. It provides a continuous signal, not pulses. The uterus contracts regardless of pain perception, emotional state, and fatigue, and the brain is not actively involved in regulating the pattern. The physiologic consequences of Pitocin often look like contractions being stronger, closer together, and less variable. Less rest in between your contractions can impact maternal endurance, uterine perfusion, and fetal intolerance. And because the brain isn't always releasing oxytocin, endorphin release may not rise in the same way, and coping can feel very different. This doesn't mean that Pitocin is bad. It doesn't mean that it's the devil. It just means that Pitocin can be a life-saving and appropriate. It just depends on what the body needs. It really, really depends if your body really, truly needs Pitocin to get through labor and birth. The key understanding is what it does and what it doesn't do. Supporting the nervous system becomes even more important when using it. So if we are using Pitocin, it's really important that you have a doula who knows how to support your nervous system in various different ways, whether that's smell, touch, sight, feeling, whatever it is. It's really important that your nervous system is just as taken care of, especially when we're affecting things that are essentially going to affect our nervous system in the long run. So Pitocin contracts the uterus. It does not recreate the brain-body feedback loops that spontaneous labor does, something to think about. And most inductions don't rely on just one of these methods. They're often all layered together. So let's talk about what layered inductions look like when physiology gets out of the sequence, maybe wholly, maybe not totally. Most inductions are not a single intervention. They are a sequence of physiological requests. And I want to be clear, I've said it before, I'll continue to say it. Some people only need one intervention. Some people need a cascade of interventions. And when I say need, it doesn't necessarily mean that they need it. Sometimes it's that they want one intervention method and then their body needs a cascade of other intervention methods. Whatever it is, I want to talk about what these look like together. So common progressions of these interventions look like a cervical ripener, into mechanical dilation, into Pitocin, into artificial rupture of membrane, typically somewhere in there asking for pain relief via epidural. Each step assumes that the previous one has created enough change. Why layering happens at all? Labor requires multiple systems to activate together. We want all of those aligned systems through our bodies so that we can actually get through labor and birth. Induction methods target individual components, not the full cascade. That's why sometimes we see a cascade of needing more medications, because induction methods focus on one part of the journey. They don't always focus on the full journey. They don't always encourage or start the full journey. When one system responds but another system doesn't, additional input is typically added or required or recommended. What out of sequence means? In spontaneous labor, we are seeing cervical ripening, contractions, dilation, descent. With induction, you might see contractions before cervical readiness, dilation without coordinated contractions, and pressure without hormonal support. This doesn't mean failure. It just means that your physiology is responding unevenly or differently than we would typically expect. And this can affect how your labor feels. It can feel more intense early. It can feel less rhythmic. It can feel way more fatiguing much more quickly. The progress does not appear inconsistent. Decisions may feel faster because multiple variables are being managed at once, but that doesn't always have to be the case. Decisions can be and take as long as you want them to be, often more supported when you have a doula in the room. When you want to take time to really make a proper decision, when you have a doula in the room, you're typically given that time a lot more easily, or they can ask for that time. They can advocate for that time to figure out what's best for the family, for everyone as a whole. Sidetrack. So understanding this, why it matters, it explains why interventions can escalate or why they can have this cascade. It removes that narrative of my body didn't work. Sometimes your body is working, but sometimes you gave it a little help there and it didn't get a clear message of what the next step was. And so sometimes we had to get a little more help here or there. Everybody's different, but it reframes the induction as a managed physiological process, not a personal shortcoming. Sometimes your body just needs layered help when it has one small piece of help. It doesn't mean you're broken. It just means some processes need help every step of the way. Others don't. And I can't leave this episode without talking about the invisible main driver of the labor process, which is the nervous system. Labor is not just a muscular or hormonal experience like I might have just made it seem this whole episode. It really is neurologic. Both mechanical and hormonal measures are initiated by your nervous system. Everything in your body has one driver, and it's your nervous system. Your nervous system has its main starter, which is your brain, but your brain connects to your whole body through the nervous system. And sometimes people don't understand this, which is totally fine, but if you just look up a picture of the body, like Google the nervous system, you would see that your spinal cord, your brain, extends through your spine and it expands out to the rest of your body through nerves. That is all the same system. That is your nervous system. Your brain is the same as your nerves. Your nerves are the same as your brain. They're all signaling to each other for a coordinated system at all times, whether it's labor and birth or whether it's walking down the street, laying in bed, whatever it is. The nervous system requires and drives so much of our life that you can't just talk about induction measures without talking about the nervous system, because at the end of the day, we are affecting the nervous system, and then the nervous system is then going to return and start to make more effects and change on our body and our experience. So, the nervous system influences our hormone release, our pain perception, uterine efficiency, and cervical response. Labor requires balance between sympathetic activation, work and intensity, and parasympathetic safety, which is progress and release. I have talked about this so many times, but I really think because of the amount of times I've talked about it, I need to do a dedicated episode on what the flip is the difference between sympathetic and parasympathetic. I see it so clearly and easily, but that's because I have trained in it, I've studied in it, I have a doctorate in it, so it's okay if you do not always understand this, but you have two systems in your body. It is your fight or flight and your rest and digest, and they constantly have to work. Everything in your body has both a fight or flight version and a rest or digest version, a sympathetic version or a parasympathetic version. When your heart contracts to squeeze and pump blood, that is sympathetic. When it relaxes and lets the blood fill the heart, that is parasympathetic. So your body's constantly shooting sympathetic, parasympathetic, sympathetic, parasympathetic signals at all times. However, if you get your body in a position, if you get your body in a state of being stuck in one or the other, it is really difficult for your body to progress naturally through labor and birth, really to progress through anything in life, because it's so required to have this even balance of parasympathetic and sympathetic response in the body. One more side note. We used to do this in the office. You would come in as a patient and we would show you the difference of where your body's sitting. Is it sitting more in fight or flight? Is it sitting more in rest or digest? And depending on where is it sitting, do you have more energy or do you have less energy? Are you utilizing some of this stress, or are you so depleted from being stuck in this state of stress that you don't have any more resources to actually function? This is something that you can see across the board through regular humans and adults. Your sympathetic, your nervous system balance really should sit in the middle. You should end up at the end of the day like 4 or 5 p.m. and still have the ability to decide what you want for dinner, decide what you're going to do for your workout. If you watch TV, decide what show you're going to watch. When you are out of those decision-making things and you're like, I don't know what I want to eat, I don't know what to do, I don't know, and you're just like kind of out of energy every day around that 3 to 6 p.m. period, your system is stuck in either sympathetic or parasympathetic. And that's not your fault, but that's something to recognize, that your body is not experiencing that even balance of sympathetic and parasympathetic as it should. Side note was so fun. Now diving back into labor and birth. Labor requires that even balance. How the nervous system supports spontaneous labor. We have safety that signals our oxytocin to flow into our body. You have so many different ways to feel safety. A lot of them is felt by your partner, but for labor and birth, a lot of it's actually the environment itself. What is the energy in the environment that is allowing you to feel more parasympathetic, more sympathetic, or balanced? Oxytocin release increases when the brain perceives privacy, support, and familiarity. A lot of times when we are going into hospitals, we do not have privacy. We don't always feel the most support, even if you have the best midwife, the best OB, the best nurses, the best partners. Sometimes the support isn't exactly what you were picturing, and that's something to really prep for. Having the support that you want in the room is something you can control. So make sure that you have the support in the room that you want, because that can make a huge difference in your natural oxytocin release. And then familiarity. If you're going to a hospital setting, some people see a place and make themselves at home and no problem. Some people need to be in a place many, many, many times to feel familiar. Some people need to be in one place for a long amount of time before they feel familiar. Whatever that is, that can have a huge effect on your oxytocin release. So if you are somebody who does not feel safe in new environments, who does not feel familiar in a hospital setting, this might be something to consider if you're wanting an unmedicated labor. It might be difficult for your body to stay in that really calm, even balanced state in a place of lack of support, in a place of lack of safety or familiarity, whatever that is for you. You changing your birthing environment might actually change your nervous system expression and how your body is actually able to go into labor or birth, which has given me a great idea. We should do an episode on birthing environments, just generally birthing environments, what that is like for people. So good ideas. Thanks, you guys. You guys are giving me ideas. Back to how the nervous system supports spontaneous labor. Endorphins will rise alongside contractions, and rest in between contractions allows the integration and recovery for mom's body so it doesn't get so fatigued so quickly. This is why sometimes you'll see unmedicated labors for some women go really long. And if they are going really long, some of those women, it's just their body fatiguing, but actually because they haven't had any other intervention methods, their body's just taking a rest so that it can jump back into an intense contraction mode and really get baby out. It doesn't always mean that labor is stalling. I've seen this a few times where, just depending on the timing of labor and birth, mom is so tired that her body does quiet down for a little bit so she can get a little rest. Then she can go into the end active labor, pushing fetal ejection reflex type stages at the end. How inductions can change the nervous system input that we experience. Hospital environments can increase vigilance. Continuous monitoring can limit movement or just comfort in the room. Timelines can introduce new pressures, new questions, I would really say pressure. It's usually pressure that mom feel like, I feel pressure. I have to be somewhere by this time, or they're going to introduce this new intervention method. Interventions can increase sensory load, and none of this is wrong. It's just a different input for the body and for the brain for labor and birth. Why this matters physiologically. Stress hormones can inhibit oxytocin receptor binding. We need oxytocin to be able to bind to all of the receptors at all times. However, if your stress hormones are not allowing your oxytocin to bind to their receptors, it's going to be really hard for you to get those pain relieving chemicals, those regulating chemicals to keep your contractions up at the speed, the pace, the frequency that they've been. Stress hormones can also reduce contraction efficiency and increase pain perception. Not ideal. Supporting regulation can improve labor progress, coping capacity, and fetal tolerance. This is why it's so important that we support the nervous system during an induction. Movement when possible. Last induction I was at, we were moving every 30 minutes, regardless of fatigue, regardless of anything. We were always moving because we wanted to support her nervous system so that the induction method could be as efficient as possible. We had low lighting. We did have low lighting. We had pretty much everything that's on this list that I'm about to say at the last induction method or the last induction birth that I was at. But these are also things that support the nervous system for an induction. Low lighting, familiar voices, touch, reassurance, breathing patterns, and feeling informed and involved in every single decision. Induction doesn't remove the nervous system from labor. It makes its role even more important. So when we understand what inductions are actually asking the body to do, we can reframe how we interpret their outcomes. Hopefully that was helpful. That was all the science, and really just big science behind why these induction measures change the body, how they change the body, so that you can make a better decision if you need an induction measure of what you want to do, or you can have a better idea of questions that you want to ask your providers if you are ever faced with possible induction starts for your labor and birth. I hope you guys enjoyed it. That was a really fun episode for me. I really, really, really love the science behind it. If you guys have any more questions or need any more clarity on specific aspects of the science, please drop a DM or comment, whatever it is, send me a message and I will try to answer it for you the best that I can. If you're enjoying the Popped Podcast, please like, subscribe, leave a comment, leave a review, whatever feels good to you. I hope you guys have a fabulous week. I'm Dr. Emily, and you've been listening to the Popped Podcast.